peace and to share our knowledge. It's very important, and connections. And really congratulate the organizers and honor for presenting in this convention.
תודה רבה, дякую. І також з нами
Thank
тут
you. And also, I just need to say that it looks like we have a problem with broadcasting in YouTube.
І зараз я хочу ще сказати, у нас є кілька хвилин. Ми надамо слово також доктор.
And we have a few minutes. We will give the floor to Rita Ehrlich, who also has roots from Western Ukraine.
Again, good morning, and thank you for the invitation to participate in this meeting. It's very close to my heart. I was also born in Vishkovo in Zakarpattia, and I came to Israel when I was very little. So for me, it's really like a lot of the speakers here, it's feeling like coming back home. So thank you for the opportunity, and sure we will have a great meeting.
תודה רבה. דякую. Thank you very much. אני לא יודעת באיזה שפה אני מדברת. אתם לא יכולים, вони не можуть, з івриту ви перекладати не будете. Мені здається, що трансляція вже працює. Так? І ми можемо починати.
Okay, looks like the broadcasting is back on and we can continue. Hello. Yes, it looks like everything is back on. Thank you for your introductions. And I would also like to give the floor to our Professor Ditkovsky with his welcome to all of the colleagues, Israeli and Ukrainian. Dear colleagues, I welcome all of you, and I would like to say that we share a lot in common. In the recent years, since the whole scale invasion aggression started, we think of your experience a lot, and we want to share our experience with you a lot. The majority of what you will hear today has already been used in our practice. So I wish all of us to have a fruitful day and to share the knowledge. Thank you. Thank you, Vyacheslav Leonidovich. Dear colleagues, dear delegates, dear Israeli colleagues. At 9 a.m. in Ukraine, we have a minute of silence for those who died due to the Russian aggression.
Шановні колеги, ми продовжуємо наш українсько-ізраїльський
Dear colleagues, we are continuing our Ukrainian-Israeli symposium on ophthalmologic treatment and management during war. From all of the committee, I would like to thank Dina Mostova because she is truly our person. I was reading her poems, and Dina, the song you wrote, almost a hymn. using AI for music and using AI for the voice, we will broadcast it in the end of the meeting. I would also like to thank Katerina Dechuk for her high expertise in organization. She is a great ophthalmologist and a beautiful woman. And we are happy for such great committee of our organization. And now I give you the floor to introduce the Israeli talks. Would you like me to introduce them in English?
So I'm very proud to present our first doctor, Dr. Aytin Tirat, that he's pediatric ophthalmologist from Soroka Medical Center, hospital that was first to receive most of the traumatized patients on 17th of October, and his lecture, Pediatric Ocular Trauma Management. Good luck.
Буде про менеджмент дитячої офтальмотравми на основі нашого досвіду у цій лікарні. Спочатку я б хотів виділити основні відмінності між дітьми та дорослими стосовно травми. Перший момент – це вплив віку. Діти менш співпрацюють з нами, ніж дорослі. На їх розповідь можна менше покластися, чи у більшості випадків вона ненадійна, існує ризик амбліопії. Друга річ – це те, що запальна реакція значно вираженіша у дітей, ніж у дорослих. Третій пункт – це їх поведінка. Ми знаємо, що діти не дуже комплаєнтні, особливо після хірургічного лікування травми. Вони часто не хочуть носити пов'язку, як ми просимо, чи захисний щиток. Вони не дозволяють закапати очі, вони часто жаліються на біль, вони можуть терти очі, що також має свої наслідки. Четвертий пункт – це проблема окультної травми. Інколи ми не зовсім знаємо механізм травми, час травми, коли вона сталася в минулому, або ніколи не дізнаємося про це. Отже, нам треба мати на увазі ці відмінності від дорослих. А як щодо підходу, який він повинен бути до огляду ока при підозрі на травму у дитини? Найперше, ми маємо припустити, що історія часто ненадійна. Нам треба припускати, який механізм та супутні травми самостійно. Ми маємо запідозрити окультну травму, оскільки часто не знаємо, який механізм чи де саме сталася травма. Часом ми не можемо відкрити обидві повіки, оскільки цилярний спазм дуже виражений у дітей, але попри це ми маємо обстежити око. Якщо ми підозрюємо розрив очного яблука, ми плануємо глибокий огляд операційний. Користь методів візуалізації обмежена у дітей, але КТ, виконане з інших причин, може бути корисним для діагностики проблем орбіти чи самого очного яблука. Випадок клінічний. Пацієнт 9 років, удар в око шнуром від банджі, тарзанки. Він жаліється на різкий біль і знижений зір. На правому оці 0,25, на лівому оці одиниця, зіниця млява на правому оці, знижений червоний рефлекс на правому оці, рухи у повному об'ємі. Визначається гіфема. Виникає зазвичай через тупу травму, через пошкодження основних судин райдушки. Симптоми – біль, світлобоязнь, знижений зір, ознаки. Ми можемо бачити кров у передній камері, нерівномірно розширена зіниця, інколи діагностуємо підвищений внутрішньоочний тиск. А ось, до вашої уваги, гіфема 8th All, або тотальна гіфема, коли кров повністю заповнює передню камеру. Тактика ведення. Що ми робимо при гіфемі? Ми повинні пам'ятати про потенційні суміжні пошкодження, такі як розрив ока, особливо у дітей, перелом орбіти. У деяких популяціях підвищена поширеність серповидно-клітинної анемії, Тому в таких спільнотах ми маємо пам'ятати про ризик оклюзії центральної артерії із підвищенням внутрішньоочного тиску, і хірургічне видалення згустка може бути потрібне таким пацієнтам. Загалом ми повинні просити пацієнта підіймати головний кінець ліжка на приблизно 45 градусів та рекомендувати відпочинок. Уникати нестероїдних протизапальних препаратів, тому що вони володіють антитромботичною дією і через розплавлення рогівки, також особливо у дітей. Тому зазвичай ми не рекомендуємо застосування НПЗП у дітей. Лежачий режим інколи з госпіталізацією може мінімізувати ризик повторної кровотечі. І зазвичай локальна терапія, яку ми рекомендуємо, включає стероїди та циклоплегію, щоб контролювати біль та запобігати синехіям. Гіфема – перебіг. З чим можемо зустрічатися у віддаленому періоді після гіфеми? Найперше – це глаукома. Виникає зазвичай через пошкодження трабекулярної сітки, шанси підвищуються, якщо має місце повторна кровотеча, може маніфестувати через роки, через рецесію кута, що може виникати після травми. Тому ми потребуємо ретельне спостереження за цими дітьми. Насичення рогівки кров'ю через токсичний вплив крові на ендотелій рогівки. Це може спричиняти амбліопію у деяких випадках і може потребувати місяці для розрішення або навіть і пересадку рогівки. Тупа офтальмотравма – друге пошкодження, про яке я хочу згадати. Проявами її є гефема, субкон'юнктивальний крововилив, пошкодження кришталика, підвивих або зміщення його, забій сітківки та розрив хоріїди, розрив очного яблука чи розрив навіть із випадінням оболонок. Відкрита травма ока – це третє пошкодження, про яке я хотів би згадати. Тут я підсумовую просто гарну статтю з Торонто, що відображає багато того, що ми маємо у нашій лікарні на півдні Ізраїлю. Вона включає 130 пацієнтів з відкритою травмою ока, 75% хлопці. Отже, відкрита травма ока є більш поширеною у хлопців.
Okay, hello everyone. My name is Ahad Ibtirat. I work at Soroka University Medical Center in the south of Israel. And my talk will be about pediatric ocular trauma management based on our experience in this hospital. So first, I would like to emphasize the main differences between adults and children in terms of trauma. The first thing is the effect of age. Children are less cooperative than adults. Their history is unreliable and most of the time unreliable. And there is a risk of amblyopia. The second thing is the inflammatory response is much more pronounced in children than in adults. The third point is the behavior. We know that children not very compliant, especially after treatment, after the surgical repair of the trauma. They wouldn't put the shield as we asked. They wouldn't allow us to put drops. They won't complain about pain all the time. And they may rub their eyes with the consequences of that. And the fourth point is the occult trauma issue. Sometimes we never know the mechanism of the trauma, never know the timing of the trauma when it happened in the past. So we should keep in mind these four differences than in adults. And what about the approach to the eye exam and suspected trauma in a child? So first, we should assume always that the history is often unreliable. We should infer about the mechanism and the related injuries ourselves. We should be suspicious for occult injury that we never know the mechanism or where exactly the trauma happened. We may not open both eyelids because the ciliary spasm is very pronounced in children. But we need to examine the eye. So if globe rupture is suspected, we should defer in-depth exam for the operating room. Imaging utility is limited in kids, but if CT done for other reasons, we can be helpful to rule out any orbital issues or maybe even the globe itself. A case study, 9 years old, struck in the right eye with a bungee cord. He complains about immediate pain and decreased vision. The vision in the right eye is 20/80 and the left eye 20/20. Pupil sluggish in the right eye, decreased red reflex right eye, and eye movements are full. It's hyphema. Hyphema presentation usually happens due to blunt injury that tears the major iris vessels. Symptoms usually are pain, photophobia, and decreased vision. Signs, we can see blood in the anterior chamber, a dilated irregular pupil, and sometimes we have increased intraocular pressure. And there is the 8-ball hyphema, or the total hyphema, that the blood fills the whole anterior chamber. Management, how we manage hyphema. So we should keep in mind the associated injuries like globe rupture, especially in kids, and orbital fracture. In some population, there is a high prevalence of sickle cell disease. So in these populations, we should be aware of the risk of central retinal artery occlusion with elevated IOP, and we might need surgical evacuation of the clot in these patients. In general, we should ask a patient with hyphema to elevate his bed about 45 degrees and to still in rest, avoiding NSAIDs because of the anti-clot effect of NSAIDs and because of the corneal melting, especially in kids. So usually we don't recommend using NSAIDs in children. Bed rest, as I said, and sometimes with admission, might minimize the risk of rebleed. And usually the local treatment that we recommend is steroids and cycloplegia to control the pain and to prevent synechia. Hyphema sequela. What are the residual things that we might have in the long term from hyphema? The first one is the glaucoma. Glaucoma usually is due to damage to the articular meshwork. And the chance is increased if we have rebleeding, and it can manifest years later because of the angle recession that might happen after the trauma. So we need regular follow-up after these kids. Corneal blood staining is because of the toxic effect of blood in corneal endothelium, and it can cause amblyopia in some cases, and it may take months to resolve or need even corneal transplantation. A blunt ocular injury, the second trauma that I would like to mention is the blunt ocular injury. Some manifestations of this injury could be hyphema, could be subconjunctival hemorrhage, could be lens injuries, lens subluxation or dislocation, commotio retina, and choroidal rupture, globe rupture, or blowout fractures. Open globe injuries, the third trauma that I would like to mention. Here I just summarized the article, nice article from Toronto that resembles a lot what we have in our hospital in the south of Israel. It included 130 patients with open globe injuries. 75% are boys. So the open globe injuries are really much more common in boys and males than females, and about 60% in young age, below 6 years old. Visual acuity in this article was at least 20/40 in about 56% of the patients. Etiology, it could be anything: glasses, knives, scissors, branch, sticks, pencil, pen, toys, other things. And the most important prognostic factor is the vision. If the vision is worse than 20/40, the prognosis is not good. And after that, the prognostic factors include the age below 5 years, retrolimbal involvement, posterior involvement of the choroid and retina, blunt injury causing rupture. Because of the high mechanism of the blunt injury that can cause rupture is a very bad prognostic factor. Wound length above 6 millimeters is a bad prognostic factor. If we have vitreous hemorrhage or retinal detachment, it is considered as a very poor prognostic factor. Another case study, 8-year-old girl, a toe injury 1 day ago, vision 6/12, zydal negative, diagnosis flap tear, self-sealed perforation, as you see here with the side photo of the topography, that we can see that it's self-sealed with some distortion of the corneal surface. And we see here the scar. And usually corneal lacerations, we need, if it's full thickness and the zydal is positive, we need to repair. And there's some considerations in primary repair in children. We need more suture tension than in adults. And usually it's much easier to over tighten in kids than in adults. We usually use non-absorbable sutures like nylon or Prolene, but never Vicryl because of the rubbing effect of the Vicryl. And we should bury the knots to prevent pain and rubbing. We usually remove the sutures in 1 to 2 months at most. Usually around 1 month, I recommend removing the suture. Doesn't matter what the age of the kid, because after that we can have new vascularization from the limbus, and the situation will be worse with the blood vessels. Sometimes we have vitreous calcerations, especially in posterior wounds, but even here in anterior wound in the cornea, if the trauma is deep enough, it can bring vitreous even to the cornea, and we need to be aware that during the surgery, and to cut the vitreal strands that come out of the wound. Here we have a case study of 8-year-old boy, horse riding, runs into a branch, and he had corneal laceration, as you see in the photo, and the lens capsule was wounded as well. And what are the next steps in this kid? So we have 2 paths for the repair. The first is primary globe repair with a primary cataract and IOL implantation, the same surgery, or I prefer myself, and I think most of the people who deal with pediatric trauma prefer first to do primary globe repair and to defer the secondary cataract and IOL later on, 2-3 weeks later, just because we are not afraid of uveitis or IOP spikes in kids. Usually they are controlled with meds, so no need to rush to remove the cataract because of the uveitis or IOP. We usually would like to have more predictable biometry later on than in the same surgery. And the capsular support would be more secure if we wait for cataract removal, for secondary cataract removal and IOL implantation than in the primary repair. This case study, this girl was sutured, had primary repair of the wound without touching the lens, without doing the cataract surgery. And we waited for the capsule to become fibrotic. We gave her frequent steroids and cycloplegics. And 3-4 weeks later, we moved on with the surgery. Here the video showing the surgery, doing paracentesis. Usually we stain the, if we suspect any vitreous, I stain the material with triamcinolone. And if there is any vitreous, I am aware of that, not to do traction and cause iatrogenic retinal tear. Here a continuous capsulorhexis. Then we, as with cutter, take the vitreous and the lens material out. Here we cut the fibrotic band, and the capsule is very, very secure and very stable. As compared to the primary repair, it's not stable in the primary repair. So here the capsule is very fibrotic and very stable, and I can trust the bag for IOL implantation in the bag. Here you see 3-piece IOL that I introduced through the main incision and put it securely in the bag without any worries about the stability of the bag. Here we centrate the IOL, it's well centered. And we close the sutures at the end of the surgery. The child is doing very well after that surgery. So after the repair, Usually, sometimes, or usually many times, we have irregular astigmatism. In these cases, I usually recommend using RGP lenses, rigid contact lenses, or if we leave the patient aphakic, it's much more suitable to correct the vision with rigid contact lenses than glasses. And another case study, this boy come with this photo. You can see here, notice irregularity of the iris. So here in other photos, we see the self-sealed perforation here. It's old because of the pigment that we see, and it's a regular surface of the cornea, so it's very old trauma. It's occult trauma, actually. And you can see here the transformation through the iris. So the trauma come from the cornea, hit the iris, and hit the lens, and caused cataract. So here we speak about the occult trauma that I mentioned in the first of my talk. Here we have a boy, 4 years old, case study, 4 years old boy, referred to us for anterior segment dysgenesis suspicion. And when we examined him, we saw actually very old trauma. It's self-sealed corneal perforation, as you see here, with glaucoma adherence. The iris is adherent to the cornea, so glaucoma adherence. So it's not anterior segment dysgenesis, it's occult trauma. It's from past trauma that we never...
Okay, hello everyone. My name is Ahad. The is vision 20/20 in both eyes. Pupils are normal, a normal red reflex and anterior segment. And when we asked him to attempt up gaze, he elevates the right eye, but he can't move the left eye up. So in this case, we have blowout fracture on that eye, and you can see here the herniation of the soft tissue, the fat and the soft tissue of the orbit through the inferior wall. Usually the blowout fracture most frequent in the inferior wall, then in the medial. They are very rare in the lateral and the superior walls. Usually we have herniation of the orbital contents, which can cause even extraocular muscle entrapment and trigger oculocardiac reflex with bradycardia and nausea and vomiting. So in these cases, we actually rush to the operating room in the same day to release the muscle to help rescue him from the bradycardia that can even become a great risk for his life, and to prevent ischemic damage to the muscle itself and muscle fibrosis. So this is what called white-eyed blowout fracture. Usually you have a kid with white eye, no subconjunctival hemorrhage, no signs of any external injury, but there is a green stick fracture of the orbital wall, the inferior orbital wall usually, and entrapment of the inferior rectus muscle. Here another kid stuck with a wooden stick behind the globe, behind and inferior to the globe, and the globe was intact in this case. Another kid who came with displacement of the right eye. There is some irritation of the conjunctiva and displacement, and if we have a look, we can see a remnant of pencil that he was stuck on the superinasal orbit, and the globe was displaced inferiorly. So in kids, we can expect anything, and there are a lot of occult trauma that we never know from the first glance what is really the mechanism and when and what happened exactly. Here another kid with the right proptosis, ankylosis, and the frozen globe. Actually, this kid with retro bulbar hemorrhage, orbital hemorrhage that can threaten the optic nerve and needs cantolysis and cantotomy urgently. The final note is that I would like to emphasize the need for ocular protection. Usually, with unilateral vision loss, we prescribe protection glasses because of the increased risk for injury to the better eye. And usually we recommend the prophylaxis against trauma to have protective eyewear for ruck-weight sports or shields helmets for other risky sports like hockey. That's it. Thank you for your listening.
My name is Rita Ehrlich, and I'm happy to present on retinal detachment in children. Retinal detachment in children is not retinal detachment in small adults. Pediatric retinal detachment is in about 3 to 6% of retinal detachments, with trauma the most common cause, followed by high myopia. It is mainly in males, and the maturity are between the ages of 9 to 12 years. Symptoms include leukocoria in about 10% of cases. Children can come with strabismus, nystagmus, or behavioral changes. Since those kids are not telling that they don't see well, in most cases, the features include, unfortunately, late presentation with poor vision, and about half of the cases present with total retinal detachment and PVR. In around 80% of cases, we will find pathological changes in the other eye. Full examination is mandatory in these cases, both of the anterior and posterior segment, and ultrasound is also an important tool in many cases. Inherited conditions that can lead to retinal detachment are more common, are important in our surgical strategies, and we need genetic counseling. We can identify also life-threatening diseases like in Marfan, and it's very important to examine the fellow eye, and in some cases we need to do a prophylactic treatment for the other eye. In these cases of the genetic associated pediatric retinal detachment, there's high failure rates and poor functional visual outcome. In our surgical approach, buckles are very important and need to be used as treatment of choice whenever possible, either alone or in combination with pars plana vitrectomy, as it's very hard to clean the vitreous well in pediatric cases. In my opinion, buckle is very important and mandatory in these cases. In patients where traction is the cause of the detachment, like in ROP, we can do a vitrectomy alone, as long as we don't do any iatrogenic breaks that can happen, and then sometimes we need to put a buckle as well, and to use gas or oil. I usually perform bilateral cases in both eyes on the same day to avoid the burden of several general anesthesia. There's faster vision rehabilitation and less pain. Usually in these cases, we need to follow that with more surgeries and EUAs. So as far as time, immediate sequential bilateral cases are, I think, in my opinion, not better. Ultrasound is key in diagnosis of many cases, as we can see here, a case of total detachment. Imaging is also very important, and there are a few cameras available, some in the office as the Optos, and some are portable and used in the OR with fluorescein options as well as color photos. Here you can see a summary of the field of view with those cameras and which ones have fluorescein angiography options. This is an example of an Optos and fluorescein images, as well as an OCT of a boy with coloboma and retinal detachment. This is a case of a total detachment, as you can see in a child. At first, I flattened the retina with either heavy liquid or you can see put Helon. Here, I examine the retina. I perform retinectomy. Usually, I don't like to do a retinectomy unless it's mandatory. In this case, it was mandatory. Otherwise, I couldn't flatten the retina. And here, I perform retinectomy, followed by heavy liquid and laser 360. As you can see here, at the end of the surgery, I exchange with the silicone oil, and this is the final result of this case. This is another case of a very bad PVR, that you can see a very large sheath of subretinal fibrosis that is removed during the surgery after I perform the retinectomy. We also need to remove the preretinal bands or fibrosis in order to flatten the retina, as we can see in this case. Here I also put a band 360. As I said before, I think in these cases, usually a surgery that combines buccal and vitrectomy is very important. After that, I flatten the retina with heavy liquid. Did a retina. As far as the genetic and vascular causes of retinal detachment, they include all kinds of diseases as fever, familial exudative vitreoretinopathy, which is bilateral, usually autosomal dominant fashion, although X-linked and autosomal recessive inheritance have been described as well. And Norris disease is an X-linked recessive disease that causes tractional retinal detachment, and there's a stock tissue adhering between the retina and the lens. Frequently, it can be hemorrhagic. Incontinentia pigmenti is another genetic disease that can cause a retinal detachment. It's an X-linked dominant. It's lethal to hemizygous males, and blindness in this disorder is typically due to retinal detachment, which occurs in 3% of patients. Stickler disease is the most frequent inherited connective tissue disorder and most common cause of the inherited childhood retinal detachment. There is at least 6 subgroups of identified according to the abnormality in the type of the collagen and present with premature arthropathy, orofacial, auditory, and ocular features. The Cambridge prophylactic cryotherapy protocol was a retrospective comparative series on patients with type 1 Stickler syndrome. In this study, the bilateral control group had a 7.4-fold increased risk of retinal detachment compared to the prophylactic group, and the unilateral control group had a 10-fold increased risk of retinal detachment compared to the unilateral prophylactic group. Other causes, genetic causes that can also lead to retinal detachment include persistent fetal vasculature. X-linked retinoschisis can cause retinal detachment in 16% of cases. Marfan syndrome, up to 11% present with retinal detachment in naive patients, and in up to 40% following cataract surgery. Non-traumatic inferotemporal retinal dialysis is also a cause. It is usually familial, and it's in young males in the second decade of life. Coats is another cause, and ROP. In summary, we need to obtain wide-field fluorescein angiography and treat prophylactically the other eye in young patients with retinal detachment. We need to recognize, especially in cases of prematurity, in cases of fever. Familial history of retinal detachment is very important, and sometimes we need to test for Stickler disease and treat prophylactically, if needed, the other eye. Thank you very much for listening.
Good morning. My name is Dr. Victoria Vishnevskaya-Dai, and I'm the director of the Ocular Oncology Service at the Shiva Medical Center, Tel Aviv University. I would like to thank the organizing committee for the opportunity to be here with you this morning and share this information about the management of uveal melanoma. So uveal melanoma accounts for about 5% of all melanomas in the human body, and it is the most common primary intraocular tumor in adults. It can arise de novo or from annulus. It can originate from the iris in 4% of cases, like depicted here, or it can originate from the ciliary body, as depicted here in 6% of cases. And the majority of cases, 90% of cases, are originating from the choroid, like depicted here. The patient could be asymptomatic or could complain on visual disturbances, shadow, and black spots. The diagnosis is based on full clinical examination, including dilated pupillary examination. In addition, we use ultrasound and photography, and in the end, OCT scans to make the diagnosis. Here is a case of posterior choroidal juxtapapillary melanoma. This is how it appears on B scan ultrasound, and this is on A scan, where you can see low internal reflectivity, and this is a large tumor, 9.6 millimeters in thickness. Here you can see that the iris melanoma is depicted on UBM ultrasound, and you can see that it does not respect the anatomy. It will invade behind the iris into the ciliary body, and if left alone, it could invade the choroid as well. So how do we treat? Usually we treat in a multidisciplinary team group. In general, these tumors respond to higher doses of irradiation, and we can reach high doses of irradiation using charged particles like proton beam, cyclotron, CyberKnife, and linear. We use linear in Israel in our hospital. Here you can see a treatment plan based on CT scan and a linear accelerator for external irradiation. This is the patient looking at the camera. This is how we know she won't move her eye. And this is the liniac, the source of irradiation that will rotate around the head of the patient. A more common treatment is scleral plaque irradiation using brachytherapy methods, and we are lucky in Shiva to use both iodine 125 and ruthenium 106, and we decide according to our goals to achieve tumor control, and we decide according to the location and size of the tumor which treatment we prefer for the patient. We want to have tumor control and minimal irradiation complication. So this is the comparison between iodine, that is good for thick tumors as well, and ruthenium, that is only good for thin tumors. As you can see, more than 6 millimeters, there is hardly any penetration of the irradiation, and this treatment is more easy to use because it is each plaque is active for at least a year, so it's not so expensive. Iod is very, very expensive. It is custom design plaque. We choose what type of plaque, how many seeds, and it is very, very expensive per patient, but it is very effective. According to the CUM study, we know on 8,712 patients that it is effective and safe. So we send our physics and tumor shape, the tumor size, and they choose the plaque and they position the seeds, and then we can calculate how much irradiation will the lens receive, how much the optic nerve and the macula, and there we can proceed the complication from the irradiation. This is how it will look. We will suture the plaque to the eye on the basis of the tumor, and it will stay there according to the plan made by the radiation. And here are some examples. This is an iris melanoma before and after irradiation treatment. This is ciliary body melanoma. This is how we position the plaque. We have the shadow of the plaque using transillumination, and you can see before and after treatment. And this is the choroidal melanoma before. And you can see that we position the plaque using indirect ophthalmoscope. We stain the sclera, and according to the position, we suture the plaque, and then we can add TTT, transpupillary thermotherapy, using a sandwich treatment. And now you can see how the tumor with time regressed to a flat scar. But this patient, since it was on the nerve, developed radiation retinopathy with cotton wool spots and some bleeding. And this is a case from tumor and retinal detachment to flat scar and no retinal detachment. So what will happen with these patients? Can we send them home? No, we have to follow them up because we know they can develop metastasis. And the thicker the tumor is, according to the Shields publications, we know that if the tumor is thicker, there is more chance for metastasis spread. If the tumor is more than 10 millimeters in thickness, 51% of the patient will send metastatic disease to the liver. And if we enucleate, we can also look at the genetics of the tumor. And if we don't enucleate, we can do final aspiration biopsy to look at the tumor, sticking the needle inside the tumor, and then sending it to cytology. This is an example of spindle-shaped melanoma, and this is a past stain for spindle cell melanoma, and this is epithelioidal type melanoma. And here you can see evaluation of the chromosomal aberration of the tumor. We're looking at chromosome 3, monosomy, and gain of 6p and 8q. These are all markers of aggressive disease. And looking at all the genetics possibilities, we can use RNA-based gene expression profile, looking at low risk and high risk melanoma. We can look at the chromosomal aberration, and we can look for specific mutations like BOP1, which is a very aggressive mutation. So this is how the patient will end up if he will send metastasis, and this is what will cause the mortality of most of the patient with uveal melanoma. So what's in the future? How can we improve the patient's survival? First of all, we emphasize early detection. We would like to use clinical signs and maybe cell-free DNA. We want to have good local control, and we will talk about the methods. And we want to treat immunotherapy for the patients with metastasis. The clinical risk factors to find small ocular melanoma: thickness, fluid, symptoms, orange pigment, and thickness and the base of tumor more than 5 millimeters. And we would rather treat this small melanoma than this one, which has more risk for spread. We can also, if we make the diagnosis early and the melanoma is less than 2.2 millimeters, we know from the Shields publication that the recurrence rate in 10 years will be only 50%, so we can use TTT. And the more risk factors the patient has, the more it is encouraged to use plaque therapy. And the newest method is the Belsar treatment, which is under investigation now here in Chiba and worldwide by AURA. This is a biological treatment where we inject protein into the vitreous or into the subretinal space, and then we activate it with PDT. It was proven to be very effective. And from the systemic standpoint, we're looking at targeted immune therapy that will encourage the immune system to fight against the tumor. And the only one that is FDA approved so far is tabentofast, the Kimtrac, which is a protein that is bind to HLA-A0201 that is specific in some melanoma cases, and it recruits T-cell lymphocytes that kill the cells. And we have some patients that survive for several years, although the preliminary phase showed that it only improved survival from 16 to 21 months. It was still statistically significant, but we have a patient that is already there for several years with metastases that regressed very nicely. So I would like to thank you again for the invitation. It was a brief review of current and future trends in the treatment of uveal melanoma. I thank you for your attention.
Thank you very much. Тода раба. Дякуємо, Вікі. І вже все синхронізувалось. Everything is synchronized. So the next one is dear Professor Arya Markovich from Lvov, and this is my favorite city in the world. And he will tell us about scleral fixation of IOLs using the plunge technique. And he's head of ophthalmology department of Kaplan Medical Center from Israel. You're welcome.
Hello, I'm Ari Markovich, Head of the Department of Ophthalmology at Kaplan Medical Center Rehovot, affiliated to Faculty of Medicine, Hebrew University of Jerusalem in Israel. I would like to present on scleral fixation of subluxated IOLs and IOL implantation without capsular support using the flange technique. I have no relevant financial interest in this presentation. Why IOL fixation became such a hot topic? Longevity with pseudoexfoliation. We see more and more late IOL subluxations or dislocation. We perform phacoemulsification despite compromised zonules. And there are long-term complications of anterior chamber IOLs that we don't want to treat, like CME or corneal edema. And there are emerging easier fixation techniques recently, like the flange technique. There are several options for IOL fixation without capsular support. Iris fixation, like we see in the upper right picture, Gore-Tex scleral suturing, Hoffman pockets, intrascleral three-piece haptic insertion using flanges, the Amane technique, and Prolin 6 or 7/0 scleral flanges, the Canabrava, which I will be speaking about. The advantages of IOL fixation using flanges is a short learning curve with shorter procedure duration, no need to create scleral pockets, and Prolin sutures can be inserted before needle insertion. A decision should be made if to fixate an existing subluxated IOL or exchange and fixate a new IOL. The advantage of existing IOL fixation is that we perform only paracentesis, the same IOL power remains, and there is no trauma of IOL removal. The advantage of exchange of an IOL, that we remove the bag and cortical remnants, it's easier to fixate a new 4-eyelet IOL, and we can adjust the IOL power according to refraction. When is it better to exchange the IOL? If the IOL is opacified. If we need to perform puncture of optic or haptic, there is an increased risk of tilt. And there are surgeons that prefer exchanging the IOL since mastering the 4-eyelet IOL fixation is easier. To prepare for the flange technique, we should cut the Prolin 7/0 obliquely and its straight part with a blade, creating two threads of about 10 centimeters, and bend 4 40-gauge needles mounted on syringes filled with BSS at 60 degrees, about 8 millimeters from the tip, to allow friction between thread and needle. Here is a schematic drawing describing the flange technique. The thread is inserted for opposite paracentesis before inserting needle. A 30-gauge needle enters 2 millimeters from limbus, passing below haptic. The thread is inserted into the needle and pulled out of the eye. The procedure is repeated with a new needle and other edge of thread above haptic. The procedure is repeated inferiorly. The IOL is centered by pulling threads. The threads are shortened and flashed by cautery. In this movie, a subluxated IOL is fixated using the flange technique. A needle is inserted below the optic-haptic junction, and the Prolin thread is inserted into the needle and withdrawn out of the eye. A second needle is passed above the optic-haptic junction, and the other edge of the Prolin is taken out, and the IOL is pulled superiorly. The iris is dilated using iris hooks, and an inferior needle is inserted into the sclera to assure the insertion of the needle below the optic-haptic junction. An intraocular forceps is used, and the needle is passed below the optic-haptic junction. Now a Prolin suture is inserted into the needle and withdrawn out of the sclera. The other edge is inserted into the needle that passed above the optic-haptic junction. Centration of the IOL is performed by pulling the Prolin thread the prolonged threads are shortened and cauterized, creating flanges, and the flanges are buried into the sclera, and the conjunctiva is freed above the flanges. The picture is of 1 day postoperatively. The flanges are well buried and the IOL is centered. 1 month postoperatively, the visual acuity was 6/7.5 with a minus 2.75 refraction. Another important technique that flanges are implemented is the implantation of scleral fixated IOL without capsular support. A 4-eyelet IOL is folded and injected above iris. A thread is passed through IOL eyelets on both sides. The IOL is centered and the flanges are created to fixate the IOL to the sclera. There are several available 4-eyelet hydrophobic IOLs. The Bosch & Lomb with a power of 0 to 34 with toric version as well. The Physiol Myopia from minus 10 to 35 diopters, and the Hanita Bani from 5 to 35 diopters. This movie demonstrates the technique of insertion of the IOL. The IOL is injected above the iris, and the spatula is assuring that the IOL will open and not fall into the vitreous. Then the IOL is centered. A prolonged suture is inserted into the eye. A 30 gauge needle is passed through the sclera and through one of the haptics, and the prolonged suture is inserted into the needle. The same procedure is performed through the other haptic, and the loop is created around the haptics. Same procedure is performed from the other side. A needle is passed through the haptic, and a prolonged suture is inserted into the needle and withdrawn out of the sclera. The second edge of the suture is inserted and passed into the needle through the other haptic and taken out of the eye. Then the IOL is pushed below the iris from both sides. After centration of the IOL, the prolonged sutures are shortened and flanges are created and buried below the conjunctiva. 1 month postoperatively, visual acuity is 615 with a refraction of planum minus 3/800. We can see the flanges buried underneath the conjunctiva and the IOL is well centered. Is it better to fixate or exchange the IOL? We looked at our 110 eyes of patients that underwent either fixation or exchange, and retrospectively studied the refractive results. We compared the results of the refractive outcomes between 4-eyelet Bani IOL fixation versus the existing subluxated IOL fixation. The astigmatism was comparable between groups. It was 2.8 in the Bani IOL fixation and 2.32 in the subluxated existing IOL fixation. The spherical equivalent was slightly more myopic in the existing IOL fixation without statistical significance. We had complications in 14% of cases. In 5.5% we had exposed flanges that we needed to cover in the second surgery. In 4.5% there was post-surgical decentration of the IOL, and in 3.5% there was corneal edema. No cases of endophthalmitis or retinal detachment were observed. In all cases we had stable and significant improvement in visual acuity. There was a myopic refractive outcome. and increased postoperative cylinder. So is it better to fixate or exchange? There was no significant difference in the final corrected visual acuity, refractive outcomes, and complication rates between the 4-eyelid bunny lens and existing IOL fixation. So to conclude, the flange scleral IOL fixation is a technique with a fast learning curve, a predictable short operation time. The IOL implantation with the 4-eyelet IOL is easy and can be used for IOL exchange or primary implantation without capsular support. Thank you for your attention.
שלום, אני דוקטור מוסטובודינה, רופאת עיניים ילדים מישראל, וביום הזה יש לי פריבילגיה לדבר גם בעברית, גם באוקראינית ולא באנגלית, אני יודעת את שתי השפות, ואז קיבלתי זכות לקהל ישראלי להציג את הנושא שלי בעברית. אז אני אדבר על ורנל קרטוקונג'וקטיביטיס, או ורנליס, כמו שאנחנו קוראים לזה, אין לי שום אינטרס הכלכלי במה שאני הולכת לספר, ואנחנו מדברים בקצרה, כולנו יודעים על מה אנחנו מדברים, ובכל זאת, מחלה הזאת, VKC, זה מחלה כרונית, בילטרלית, אלרגיה, סוג של אלרגיה עינית, שלפי הסטטיסטיקה אנחנו פוגשים יותר אצל הבנים בגילאים 6-7, אבל כמובן לא כולם קראו את הספר, אז כמובן יש הרבה אצל הבנות, וגם בגילאים צעירים יותר, מאוחרים יותר. לפי הספר יש התקפים תקופתיים של המחלה, למרות שכפי אנחנו יודעים, לילדים יש את זה במהלך השנה כל הזמן, מאוד נפוץ במזרח התיכון בו אנחנו נמצאים, כמו שהרבה דברים אחרים נפוצים במזרח התיכון. אז מחלה של ורנל קרטוקונג'וקטיביטיס, אנחנו מאבחנים אותה לפי התסמינים הקליניים וגם היסטוריה קלינית וסימפטומים מאוד קלאסיים. אנחנו מדברים על ילדים עם עיניים אדומות, מגרדות, נורא סובלים מאודם, פחות מאודם, נורא סובלים מגירודים, משפשופים, ילדים שפוטופובים, פוחדים לפעמים לצאת החוצה, לפעמים בוחרים לא ללכת לבית הספר, דמת, אי נוחות, פגיעה באיכות החיים, מבחינת כל הביטויים הקליניים שאיתם הם מגיעים אלינו למרפאות. פתופיזיולוגית מדובר ממש בסוג של תהליך אטופי, ולפעמים להורים אני ממש אומרת שמדובר באסמת עיניים, כי התהליכים הם מאוד דומים לאטופיק דרמטיטיס ולאסמה נשימתית, כאשר מדובר באינפילטרציה של האזינופילים, התאים של האלרגיה, לימפוציטים והיסטאוציטים של רקמת של לחמית, פיברובלסטים שעושים את השינויים הפרוליפרטיביים, גורמים ממש לשינוי סטרוקטורלי של הלחמית. אז יש 3 ביטויים קליניים של ורנליס, ששניהם יכולים להיות גם מעורבבים. קלאסי של טרזלי, הביטוי הקלאסי של טרזלי זה giant papillary conjunctivitis, פפילות הגדולות, הענקיות. בביטוי הלימבלי אנחנו רואים רקמה מעובה של אזור הלימבלי, עם טרנטס דוטס, עם נפיחות. יכולים כמובן להיות ביטויים קליניים מעורבבים, והרבה מקרים אנחנו רואים גם וגם. ואם לא מטפלים במחלה הזאת בזמן, חוץ מזה שילדים נורא סובלים, יש לזה סיבוכים והשלכות קשות. אחד מהם הקשה ביותר בתקופה אקוטית לא מטופלת זה שילד אלצר, הפגיעה באפיטלי של הקרנית, וילדים האלה ממש מגיעים לאשפוז, או ביטוי של הסיבוך מאוחר יותר, שתמיד אנחנו צריכים לחשוב עליו, על ילדים שמשפשפים עיניים, ולא סתם את סבתות היו אומרות לנו לא לשפשף עיניים, כי יש לזה באמת השלכה מכנית, כולם יודעים, מחלה בשם קרטוקונוס, ואף אחד מאיתנו לא רוצה את זה. אז כולנו יודעים, כולנו מבינים, מחלה נפוצה, וכרגיל כל דבר נפוץ, אף אחד לא באמת יודע מה עושים איתו. ויש מיליון גישות, ועדיין אין פרוטוקול מסודר. אז הגישה הקלאסית היא לטפל בתסמינים יומיומיים, כלומר לתת טיפות לחות, מכיוון שמדובר באלרגיה, אז לאזן את התהליכים האלרגיים, כלומר להשתמש בטיפות מסוג של mast cell stabilizers, אנטי-היסטמיניות, וכולנו יודעים שזה לא ממש עובד, והפלא הקלאסיק סטרואידים, שמוחקים את כל התסמינים, מדכים את מערכת החיסון, זה דבר מדהים, רק עם המון תופעות הלוואי, וכולנו יודעים איזה, במיוחד אצל ילדים, שאף פעם אין באמת ממש אפשרות לבדוק להם לחץ תוכני, למרות שכבר הרבה יותר טוב, ולחץ יכול לעלות, ואף אחד לא יודע מזה, וגם קטרקט מוקדם שיכול להתפתח, ולכן אנחנו חוששים מטיפול בסטרואידים ולופ חוזר, אבל בשנים האחרונות, יותר מ10 שנים האחרונות, הופיעה סדרה של טיפולים אימונומודולטוריים, topical immunomodulators, שזה ממש שינה לנו את כל הכללי המשחק. אז הראשון שהופיע זה טיפות של ציקלוספורין, ובהמשך כולנו הכרנו פלא של דבר, topical תקרולימוס. תקרולימוס זה תרופה גם כן מקבוצה של אימונומודולטורים, שהמנגנון שלה זה קלצינוירין איניביטור, כלומר תהליך שגורם לדיכוי של T לימפוציטים אקטיביישן, דיכוי של אקטיבציה של תאים החשובים בתהליך המחלה. התרופה הזאת קיימת במדינת ישראל בכמה סוגים, בכמה צורות, אנחנו לרוב משתמשים במשחת אור שהיא מכילה את התקרולימוס, וכמובן כולנו יודעים שקיימות גם טיפות של חברות פרטיות או ייצור פרטי של קופות החולים או בתי החולים, גם בעולם יש ייצור כזה או אחר של תקרולימוס בשביל שימוש עיני, אבל זה אוף לייבל, כלומר אין באמת אישור רשמי לשימוש בתרופה הזאת, ויחד עם זאת זה משהו ששינה לנו לגמרי איכות החיים. וכאן אני עוצרת בשביל להציג גם מאמר שפרסמנו יחד עם קבוצה של רופאים מדהימים שאיתם עבדתי פעם באסותא אשדוד, ואופטומטריסטיות מדהימות שאיתם עדיין אני עובדת עם חלק מהן, ועשינו אנליזה של המטופלים שטיפלתי בהם במרפאה עצמאית שלי במשך 5 שנים, ומה שחשוב להגיד שהרעיון הגיע מאותה סיבה שבסופו של דבר אף אחד לא באמת יודע מתי להתחיל טיפול בתקרולימוס, מתי להפסיק, באיזה תדירות לעשות את זה, ומה נכון ומה לא נכון, עד היום זה לא ברור, אז ניסינו לעשות קצת סדר, וממש בקצרה, כי אין לי הרבה זמן, מה שניסינו לעשות זה להשוות קבוצות שונות של מטופלים, אלה שטופלו בסטרואידים ותחליפי דמעות, בסטרואידים ותקרולימוס ותחליפי דמעות, רק בתקרולימוס, או עברו מטיפול של סטרואידים לתקרולימוס, כלומר חילקנו את המטופלים ל3 קבוצות, כמו שכבר אמרתי, המחקר הוא רטרוספקטיבי, הקבוצות אנחנו חילקנו לפי חומרת המחלה, היו ילדים שנכללו לקבוצה של מיילד, מודרט וסיביר, לפי הביטויים של ורנל קרטוקונג'וקטיביטיס, אלה שהייתה להם מחלה קלה, טופלו רק בתחליפי דמעות, או תחליפי דמעות עם סטרואידים פעמיים ביום ולא יותר, בתקופה קצרה, מודרט טופלו גם בתחליפי דמעות ויותר בסטרואידים, 3-4 פעמים ביום, לתקופות יותר ממושכות, וסיביר זה אלה שטופלו בכמובן תחליפי דמעות, בסטרואידים, ובסטרואידים מההתחלה ואחר כך בפרוטופיק תקרולימוס, או שישר בפרוטופיק. ובתוצאות אני נציג ממש בקצרה, אז בסך הכל היו 105 ילדים בתקופה הזאת של הבחנה עם ורנל קרטוקונג'וקטיביטיס, מתוכם בסופו של דבר 20 לא השתתפו באנליזה של המחקר, כי היה להם או שיתוף פעולה נמוך או בכלל נעלמו מהמעקב, אז מדובר ב85 מטופלים שחולקו לקבוצות של מיילד, מודרט וסיביר, ממש בקצרה, אני לא מתמקדת יותר מדי על הטבלה הזאת, אבל צריך לציין שבקבוצה שטופלה על ידי פרוטופיק, היה פחות צורך במעקב ותקופה של רמיסיה יותר ממושכת. ואלה המסקנות שהגענו אליהם, שילדים שישר קיבלו, במחלה קשה כמובן, קיבלו פרוטופיק ולא היה ניסיון למשוך אותם עם טיפול בסטרואידים, הם בסופו של דבר הגיעו לצורך של פחות מעקבים, פחות התערבויות במהלך היום, מה זאת אומרת, כששמים רק משחה פעם ביום וטיפות לחוט, לעומת מלא כמויות של הטיפות, זה ממש משפיע אחרת על איכות החיים, אז היה להם צורך פחות להשתמש במשחה, פחות להשתמש בטיפות, ופחות צורך בלהגיע למעקב, לעומת הילדים שהיה קודם ניסיון לטפל בסטרואידים, ואחר כך לעבור לטיפול בכל זאת לפרוטופיק, לא מדובר כאן במיילד מחלה, שחלקם גם כן הפכו להיות יותר קשים, ובסופו של דבר הגיעו לטיפול בפרוטופיק. אבל השורה התחתונה, שאלה שהיו צריכים טיפול אינטנסיבי, פרוטופיק נתן תוצאה מדהימה, ואין שום חשש לטפל בו, אז לא לחשוש מאימונומודולטורים, כן לטפל בהם, ולזכור שאנחנו גם משפרים להם איכות החיים היום, וגם מונעים מחלה קשה בעתיד. תודה רבה, דякую. I'm so happy that I finished to talk. It's also my favorite topic, and I think this is very important also for us and also for Ukrainian specialists. And now the next our presenter is Professor Tamara Vignansky-Yafe. Will tell us about amblyopia news, and she's head of Pediatric Ophthalmology Unit, and also she's president of International Pediatric Ophthalmology and Strabismus Council. So welcome, Professor Vignansky.
What's new in amblyopia treatment? Availability of amblyopia treatment in different parts of the world. That will be the topic of my lecture. So the standard of care for amblyopia is patching, first described so many hundred years ago. The problem, however, is poor compliance, recurrence, and residual amblyopia. Still, the biggest issue with patching is that the treatment for so many children and families is actually worse than the disease itself. And we know in a whole child approach that amblyopia affects not only visual function, it affects reading, visually guided skills, self-perception, and the quality of life of both the patient and the entire family. And here you can see a child who reads well on the left, and he browses nicely through the text. And here is the reading of the amblyopic patients, which is slow. So we know that 80% of visual acuity improvement with patching in children younger than the age of 7 occurs already within the first 6 to 12 weeks, so 3 months. And after that, complete recovery of amblyopia may take years, and we patch for years, and this may have a lot of impact on the child's life. These are just some reactions to patching. Some are okay with it, some just fall asleep, and some will never have a patch on their eye for more than a minute without parental guidance. So I'm a parent and I want to know what's new in amblyopia treatment, and this is what I got. Luminopia, Cure Sight, Revital Vision, and Vivid Vision. And we'll talk about monocular treatments for amblyopia, binocular treatments, and finally pharmaceutical treatments. So patching, many of us patch, and that's the gold standard, but why don't we use monitors? Why don't we actually know how many hours a day we patch? That could increase the adherence and make us know if the patching is not effective or if it's just not being done. Unfortunately, these very, very cute monitors are not being sold anymore. Well, what else do we have with patching? This is called a Cartoon Panda app, and it was developed by Southampton Hospital in the UK. This is a novel approach. We know that so many kids love their smartphones. So here the smartphone will tell you, first of all, if you patch correctly and wear the patch all the time. And it will also involve the kid in games and give him all kinds of prizes. And this is how it works. And it has been released already in a beta version, which is still preliminary, but it's available on the App Store, and it costs just short of £3 per month. Another really good option were the Amblies, or the liquid crystal glasses. This is a monocular treatment whereby there's intermittent occlusion therapy, but without a patch, and the spectacle of the lens closes and opens and moves from a transparent state to an opaque state every few seconds. And this actually has been shown to be as effective as patching in children 3 to 7 years old for treating moderate amblyopia. Unfortunately, they're expensive and not widely available. But we know from many studies on many levels that amblyopia is a binocular problem and not only a monocular one. Therefore, it makes sense to encourage binocularity, increase adherence, and aim at reducing intraocular suppression. So the first company to come out was Myopia. They have this headset with goggles, which is coupled with a smartphone, and the treatment treats amblyopia by reducing contrast, but also using complementary masking. And they showed that Myopia improves visual acuity by 1.8 lines at 12 weeks compared to glasses alone. They did not compare this technology to patching, and also there was a problem with the goggles being heavy and only 3 PD sizes, but I think that can be resolved in the future. In addition, there wasn't enough content for older children, but that is also something they can add to their technology. And this is how it works. You can see in the dominant eye, the contrast is reduced. The weaker eye has areas of clear vision, and Myopia is available today only in the US, but it will be available in other countries in the future, and there is partial insurance coverage. Next is CureSight by Novasight. CureSight uses red-blue glasses to create a dichoptic environment, so there's no goggles, and it incorporates eye tracking software to allow the device to selectively blur and reduce contrast only in the fovea of the dominant eye, and the magnitude of blur, as you can see here, can be increased or reduced as far as visual acuity improves. So if visual acuity is poor, you have a large circle, but as it improves, the circle of blur becomes smaller and smaller, and the peripheral fields here are not blurred, so it encourages binocularity. CureSight has a large digital platform, and they can use every or any content streamed on the internet. We can also place parental controls. So if the parent wants the child only to see educational content, they can do it. And they showed improvement of 2.8 lines of visual acuity at 16 weeks. And they're the only FDA approved technology to be formatted for improvement of stereo acuity as well as visual acuity. CureSight is available in the USA, Italy, and Israel, and will be soon available also in Germany. Next is Revital Vision, and Revital Vision uses perceptual vision therapy in enhancing visual acuity and contrast sensitivity, and it is also used in adults. And if you take a look at this is called a Gabor, and it uses perceptual learning in the shape of Gabors, and Gabors are very effective because our brain is actually hardwired to notice the contrast, and they showed improvement in 2.6 lines after 45 training sessions, and they're the only FDA-approved device for treating amblyopia in adults. However, there are issues of compliance and you need a lot of hard work. So if you want to get a driver's license and you're missing 1 or 2 lines, definitely you're going to do it. But for others, this type of treatment may be slightly boring or monotonous, but they are software only, which is a great advantage, and distributed through several countries. Vivid Vision, another device, also using goggles to perform binocular training. Again, the weak eye has a clear vision, and the strong eye has blurred vision, and you can play games. And they also showed that in a median age of 12 years, there was 1.32 lines improvement in visual acuity at 20 weeks. And that was better than comparable to patching. But the RCTs on binocular treatments only included patients with anisometropia, small angle strabismus, and combined mechanisms. But what about all those children with strabismic amblyopia or deprivation amblyopia? What do we do with children who have cataracts? So we're back to pharmaceutical treatments, and the concept here is that there is a critical period of visual cortical plasticity, but we can extend that using all kinds of drugs and make this period extend. And this is done in the brain by using cholinergic signaling. So the first drug is donepezil, which is actually FDA approved for use of cognitive impairment in Alzheimer's disease, and it inhibits cholinesterase cholinesterase in the brain. And here, subjects in the small pilot study took the medications for and patch for 2 hours a day. And at a final exam with no treatment for 10 weeks, they actually found improvement, and the subjects improved by 1.2 lines. This was a pilot study with no control group. However, they only took patients who did not further improve with patching only. Another treatment, which is only tested on animals at this point, is tetrodotoxin or TTX. This is a very potent sodium channel blocker, and it blinds the eye and eliminates all retinal activity. Tetrodotoxin has been shown that when you inject it through the pars plana, and you need to do 2 to 3 injections 2 to 3 weeks apart, it blocks all visual acuity. So you don't have any optokinetic nystagmus, VP is dead, and you do have a relative afferent pupillar defect. And this recovers completely after 72 hours, so it's a reversible toxicity. But here, the dominant eye retina, which is temporarily and reversibly silent, showed 65% improvement in visual acuity in 3 different mammal species. So these are encouraging results and actually support further testing both in animals and possibly in the future in humans. So in conclusion, although for many optical correction and patching are still the mainstay of amblyopia treatment, a larger repertoire of treatment options will help improve both compliance, which is really important in amblyopia treatment, and also vision outcomes. Combination therapy will probably be much more prevalent in the future. And there's also a question of cost and availability. Just mind you that there are also many countries in which pediatric ophthalmologists, pediatric optometrists, and orthoptists are not available. And in this article from JAMA Ophthalmology, you can see that many areas, even in the US, are not covered by pediatric ophthalmology services. Look at all these areas. So in conclusion, we want to have a larger toolbox for treatment, and it's imperative that amblyopia is diagnosed and treated as early as possible, but advances in screening will possibly also give hope for earlier detection and better treatments. So I'd like to thank you for having me, Diakoyu. And hi, Budimir. I hope I'm saying this correctly, but really, we wish you all warm regards from Israel. Thank you.
Thank you very much. It's so important and so amazing issue, and it's our future to change the things. And the next one is Professor Yair Morad, that, as I said, grateful to him, we have this meeting, and he will tell us about what's new and exciting in myopia control. He's the head of Pediatric Ophthalmology Unit in Shamir Medical Center. So let's hear him.
Hello, my name is Professor Yair Morad from the Tel Aviv University in Israel, and today I'm going to speak with you about slowing down myopia progression, what's new and important. You know that myopia rate around the world is increasing, and it's projected that by 2050, 50% of the world population will be myopic, and 10% will suffer from high myopia, which has very severe complications, such as retinal detachment, myopic maculopathy, cataract, glaucoma, and even more strabismus. You know that today we see many patients with esotropia that is caused because of the myopia. And it's very important to stop myopia progression. So let's see, first of all, what influenced the creation of myopia. First of all, genetics, and this we cannot influence. You know that today there are more than 20 genetic loci that we know are coding for myopia, and we know that if both parents are myopic, there is a 6 times chance that the children will be also myopic. And also, and that's another thing that we can influence is the environmental factors. And what are the environmental factors? Let me tell you about a study that we did in Israel. In Israel, there are 3 education systems. One education system is of the ultra-Orthodox Jews. They start learning to read and write at the age of 3 years, and they spend about 16 hours a day, every day, in learning, reading, and writing inside a school class. And on the other hand, they cannot use smartphones or computers. Another stream of education is the Orthodox education. These children start learning at the age of 6, but spend, additionally to the time they spend learning, they spend few hours, additional hours every day reading and praying indoors. And there is the secular system, which is very similar to the secular system in Ukraine. And in Israel, like in Ukraine, I guess, every citizen have to come to the IDF recruitment center at the age of 16, and then they measure his refraction and visual acuity, and we have a huge database. So let's look at this database and see what happens to the children from the 3 educational system when they reach the age of 16. Well, the myopia prevalence in the ultra-Orthodox system is 82%. 82% of children are myopic. In the Orthodox systems, 50% are myopic. And in the secular system, only 30% are myopic. Look at this amazing difference. And I want to remind you that these are people from the same genetic background, living in the same country. The only difference is the time they spend every day reading, learning inside a classroom. 82% as opposed to 30%. So prolonged near work is a very important factor in the creation of myopia, and there are many studies to prove that. And another factor is light. And another study that we did in Israel shows this very interestingly. This is a study that looked at the season of birth of a child, the amount of natural light in this season, and the rate of myopia at the age of 16. It was, again, a large study of the recruits for the IDF recruitment center, almost 300,000 recruits. And we looked at the light intensity at the month of each one of them was born and their prevalence in myopia. And what we saw is that those who were born during the summer had more myopia. In the summer, we have more light. So at the first glance, that looks odd. More light should be less myopia and not more myopia. But if you think about it, babies spend the 4 or 5 months of life usually indoors, and they start going out at the age of 6 months, let's say. So babies who were born in January spent the summertime. They reached at the age of 6 months, it was summer. They were more outside. And those who were born in July, when they reached the age of 6 months, it was winter, less light. So those who were born in January actually had one more summer over those who were born in July, and that was enough for them to be less myopic at the age of 16. Amazing. And of course, reading in dim light is the worst thing you can do, and there are many studies that shows that. So how can we stop myopia progression? Well, atropine today is used around the world. It's following the ATOM study in Singapore, and I guess most of you know this diagram, and they showed that atropine at the 0.01% was the most effective in the long term for the arresting of myopia progression. And today, in many countries around the world, we use atropine 0.01 to 0.05 to arrest myopia, and it's common today in Israel. Every child can get it through the public health system. But we have problems with atropine. First of all, the accessibility is not very easy because it's not manufactured by the pharmaceutical companies. You have to do it in a pharmacy. Second of all, a problem is the side effects. Many children are suffering from glare in bright light and blurry vision for near because of loss of accommodation. And another problem is the rebound effect. When you stop treatment, the myopia progresses very rapidly. So it is obvious that we need another solution. And today we think that probably optic measures are the best solution to treat myopia progression. And it's all started in animal studies that were done in monkeys that were fitted with spectacles that permitted unrestricted central view, but hyperopic defocus in the periphery. And when you do hyperopic defocus, you accelerate the axial length grow and you get more myopia. And if you do the opposite, you have myopic peripheral defocus, you actually inhibit the growth of the eyeball. And today this is used to arrest myopia. And I can show you what's the logic behind this. Here you can see on the left an eye of a myope, and he is uncorrected. And you see that what the periphery sees is hyperopic defocus. The image is outside the retina, and what happens is that the retina is growing towards the image and the eyeball is growing. And if you put correction, you make the situation even worse because you make the hyperopic defocus even worse. On the other hand, if you design special glasses or special contact lenses that shifts the focus in the periphery inside the eyeball, it's now a myopic defocus. You cancel the signal that makes the eye grow, and then you can get arresting of the myopia progression. We can do that with ortho-K contact lenses, and you know that ortho-K contact lenses reduce myopia progression by 40 to 50%. There are also contact lenses with peripheral defocus that also inhibits myopia progression by around 40%. But the problem is that if you suggest contact lenses to parents with children with myopia, this is usually what they say. The parents doesn't like contact lenses in small children. So it's obvious that the solution is glasses. And today we have several glasses made by the optical companies that are known to arrest myopia progression. They can slow myopia progression by the rate of 40 to 60%, which is similar to what you see in atropine. And more importantly, there is no rebound effect and no other side effects. And in Israel, we also designed glasses like that by the Shamir optical industry, and this is what we use in Israel. So let me tell you now, how do I treat children with myopia in my clinic? And I think this is the way to treat children with myopia. First of all, when a child with myopia comes to your clinic, you have to assess the risk. The age is very important. As younger children with myopia tend to progress rapidly, much more than older children with myopia. What about the parents? Are the parents myopic or not? If the parents are myopic, the chances that this child will be more myopic are higher. How many hours does the child spend outside in bright daylight? Very important. How many hours does he spend in their work, in front of the computer, in front of the tablet or the smartphone? You have to assess the risk of myopia progression in this child. And then you'll do the axial length measurement and cycloplegic refraction. And these are very important, and especially axial length is very important factor when you decide how to treat the child. Because we know that there are curve growth of axial length. This is a study done in Holland that examined almost 13,000 children, and we know exactly if you look at the axial length at a certain age, you know what are the chances of the child to develop high myopia in the future. So, and today there are several online websites that you can put this data into the website and get the results. And I'm going to show you, this is one of the website I'm using, myopiasolution.com. And let me show you, this is a child which 10 years old, refraction of -1, and his axial length is 22.3 to 22.4. If you put this data on the chart, you see that he is in the 50 percentile. This child is not at risk for high myopia. We can give him glasses to arrest myopia, and you can even not treat him at all. I don't think he will get to -6, -7, and so on. On the other hand, if you see a child which is 7 years old with myopia of -3.5, and this is his axial length above the 98th percentile, this is a child in high risk. This child is going to develop high myopia if we won't treat him. So this child has to be treated vigorously. And there's another, according to other studies, we know that the goal is that the refraction will increase no more than 0.35 diopters per year, and the axial length will increase no more than 0.25 millimeters per year. These are our goals, and this is what we want to achieve. So when you look at the treatment, what we need to do is a pyramid of management. The basic level is to control the environmental factors. Less knee work, more time spent outdoor. For instance, tell the mother that you have to make sure that the child is out of the home 2 hours a day. The difference in light intensity between indoors and outdoors is in order of magnitudes. Indoors is less than 1,000 lux, outdoors can be 70,000 lux to 300,000 lux. It's an amazing difference. So 2 hours at least a day outdoors. The second thing is to avoid reading in dim light, as we saw. Very important, which this can make the myopia progress very fast. And when they want to use the computer, I'll tell my patients, use the computer for a distance using a portable keypad. Maybe you can even connect the computer to your television. Television is not a problem. The problem is near vision. So this is one thing, one suggestion that we can do to give the parents. And then I personally prescribe myopia control glasses or contacts to all the children and start following them and examine them every 6 months. And in every visit, I examine the cycloplegic refraction and the axial length. And this is a child with a good response. You see that the axial length is actually not growing. It's cutting through the percentiles and it's almost not moving. So this is a very good response to the glasses. And this is a child where, despite the glasses, is continuing to grow, and we need to intensify the treatment. And how do we intensify the treatment? We add atropine. I always start with 0.01% atropine because this is the concentration with the minimal side effects. But if it does not work, I can increase the dose to 0.05 or even 0.1%. And then we continue the treatment and don't stop until the child is at least 12 years old and reached a plateau in myopia progression. Two things, 12 years old and plateau in myopia progression. And then we stop. And now how do we stop atropine? We never stop atropine at once. We always do it very gradually over 6 months period. Every month we give 1 day less of atropine. Like the first month we give the atropine only 6 days a week. Then every week. The next month only 5 days a week. the month after only 4 days a week, and so on until we have only one atropine per week, one drop per week, and then we stop. And when we do that, the rebound effect is very, very minimal. Okay, so let me just share with you our experience in my clinic with the use of atropine and the glasses with the peripheral defocus. We started that in June 2023. 130 children received glasses. The glasses were well tolerated. No child refused to wear them because after a short adaptation time, they really adjust to the glasses. And after 6 months, 67 of the children completed the 6 months follow-up, and we saw that 70% of them did not need any atropine, so we could throw the atropine to the garbage. There is no need to use atropine, only glasses, and they don't feel it. They feel like they have normal glasses, and the myopia is not progressing. 30% progressed despite the glasses, so we had to give them to intensify the treatment using atropine. There were also children who were treated with atropine before I gave them the myopia progression glasses, and see what happened to these children. So 80% of the children that I gave them myopia progression glasses, because they continued to progress despite atropine treatment, stopped progressing. So when you combined atropine and myopia progression glasses, you can get an 80%, there is an 80% chance that will stop the progression of the myopia. And those who continue to progress, it can always intensify the atropine dose more. So to sum up, let's remember our primary goal is to keep the child below -6, because -6 and above, this is where we get the complication of myopia. And this can be done while keeping the child very happy. Thank you so much.
Thank you. Thank you, Professor Morad. Дуже дякуємо. Вау, це дуже цікаво.
Thank you very much.
And now tell me, скажіть мені, будь ласка, я продовжую представляти, чи ви вже представляєте українську?
Should I continue presenting, or are you going to present the Ukrainian speakers? Yes, Dina, we are ready. Thank you very much for moderating over the first part. Together with you, the whole presidium is present here. And yes, our Department of Ophthalmology of Postgraduate Studies of the National Medical University, you've got 4 professors in front of you, and in the audience are teachers, but also the present delegates. If you don't mind, we'll move on to our part and then do the discussion, because we've developed a lot of questions in the meantime from Professor Balino and Zhurek, so we are quite ready for the discussion. But now I would like to pass the mic on to Oksana Vasilyevna Petrenko, our professor of the Department of Ophthalmology. Oksana Vasilyevna actually right now is working on such an important topic as the recovery of the upper part of the face, specifically the plastics of the upper facial part, and does wonderful surgeries and the repeat surgeries as well. Right now we're working on developing the Ukrainian prosthetics. We are now developing bioprosthetics, individualized and tailored to every single person, and she's going to tell us that. So Oksana Vasilyevna, the floor is yours. Thank you. Good afternoon, dear colleagues. Indeed, very relevant as of today, a conference and the international symposium, because we have an opportunity to share our personal experiences, hear most interesting presentations at the highest international level, and having this adjacent experience, we can come to a common goal, which is the help and care for our patients. And right today, I would like to talk about the features of the mind-blast trauma in children. Because we can see, we see these children. We are aware, and according to the studies conducted in Ukraine, every day 2 children die and 4 are injured. It is difficult to estimate a factual number of those who've been killed or injured because this statistics isn't active at the moment, but of course it will be available later on. Most frequently, ophthalmologists have to do with mind blast injury, and children become potential victims of military action. Traumatic injury of eyes of periorbital area, as experience shows, is the most severe. Ophthalmologists most frequently have to face these kind of occlusive type of injury with burns of the periorbital area, with combined trauma, with cumulative trauma. And of course, the experience of our ophthalmologists, the experience of Israeli ophthalmologists is some of the largest, the most comprehensive in the world. It's obvious that the features of the eye injury are going to depend and caused by the factor that caused the injury. Talking about the traumas of today, we're talking about the mechanism of the mind blast injury. And this mechanism of the mind blast injury relates to certain actions of the mind blast explosions and munitions. The primary action has to do because in the moment of explosion, such a blast wave, it's so powerful, the blast wave that affects human body, that its speed reaches 8,000 meters per second. Of course, the larger the munition and the closer the person is to the blast epicenter, then the most severe the trauma is going to be. But after the explosion, the pieces form, which at huge speeds start flying in all directions, bringing additional mechanical trauma with them, and the injuries have a lacerated character and they're also contaminated. Then, when the person falls, they, of course, get injured by the objects they fall onto, and during the blast wave, the person may, end up under the objects of the environment, and which infringe additional trauma upon them. So we have a combined injury. And of course, the factor of, you may say, the fireball temperature, which may reach 3,000 degrees Celsius, that causes the burn injury. And therefore, we have our patients with multiple injuries, with combined trauma, cumulative trauma, almost 90% of cases. The trauma is very severe, and very frequently, it's a bilateral injury of both eyes. A significant portion of these injuries are penetrative eye injuries with a significant number of foreign bodies, both in the anterior and the posterior parts of the eye. Of course, such injuries, they are characterized by a certain polymorphism, and it's a combination of the traumatic injury of the optical environments and retina. The injuries are unfortunately complicated by hemophthalm, retinal detachment, high incidence of infectious complications. And to recover such patients is, of course, very, very difficult. But also incredibly important is the certain organizational, logistic aspects in the diagnostics of children with this kind of trauma. This is something we heard about today on the first presentation of our colleagues, who also emphasize the correct diagnostics of the foreign bodies, emphasize the fact that you cannot try to remove these foreign bodies, but they can be delicately removed by our colleagues of vitreoretinal surgeons, especially when it has to do with the posterior chamber. Also, the practice of primary enucleation cannot be applied because sometimes what seems we cannot do, our colleagues can. And the most valuable thing that we have, especially for our children, that's preserving the function of the eye. And of course, that's an adequate prevention of complications. And if we're talking about pediatric injury in the time of war, it's very important to stick to certain rules that we have to teach our children. These are as follows. If there is an area where military action used to happen, where occupation forces were present. In no situation, and this is something that should be told to children and to adults, you shouldn't pick up any foreign objects, toys, anything. You never know what is in it, and even seemingly the simplest toy can lead to a very powerful mind blast injury. And so we teach children that if you've spotted a suspicious object, do not attempt to pick it up, do not try to approach it, because that all is potentially dangerous. But if the injury has occurred, then we know very well what to do. You don't not need to apply a tight bandage, tight dressing, because that can lead to an even more severe trauma. You should use a shield that should be bandaged to the face, and thus we can ensure the protection of the eye and take the patient onwards along the stages of evacuation. So knowing about this trauma, having certain experience, using the simplest things like this, we can preserve the eyesight of our children. Thank you very much for your attention. We have, in our section, we have many presentations ahead of me where we're going to stop at. And of course, we'll have a discussion later on to discuss all the relevant issues. Thank you. Thank you. Thank you, Oksana Vasilyevna. The next presentation is going to talk about complex issues of traumatic glaucoma and ways to resolve them. And Irina Vasilyevna Sharhorodska is going to talk about that. Dear colleagues, good afternoon to everybody. When talking about trauma, we cannot miss the issue of traumatic glaucoma. My lecture has no conflicts of interest. As of today, when talking about glaucoma, we are based on the international standards and guidelines that state that every patient should be approached individually. Secondary traumatic glaucoma belongs to secondary open-angle glaucoma. And you can see the latest classification. You can see the main types of the secondary traumatic glaucoma open-angle that also includes iatrogenic open-angle glaucoma, which has to do with acquired diseases. And here we need to remember that we're going to talk about the trauma, uveitis, prolonged intake of steroids, tumors, and retinopathies of the prematurely born. And all of them can lead to the increase of intraocular pressure in the eye, and trauma is something that we're going to focus on today, specifically. The pressure increase in the affected eye due to different mechanisms. But first of all, we need to recognize that still there will not be a glaucomic injury, a glaucomic neuropathy. We're not going to talk about glaucoma so much as that we're talking about secondary traumatic ophthalmic hypertension. Traumas, as our international guidelines state, they can be classified as two big categories: the closed trauma and open trauma. And when we look at our patients, we must understand the mechanisms that can potentially lead to secondary traumatic glaucoma. And you can say a closed injury can have the consequences of the early onset, so traumatic ephema, traumatic iritis, injury to trabecular net, and suprachoroid hemorrhage. But then also late onset, recession of the angle, pacomorphic glaucoma, pacolytic glaucoma, glaucoma of the cost cells, hemolytic glaucoma, hemosiderotic glaucoma, and traumatic fistula of the carotid cavernous sinus, and the consequences of the open injury, which is the growth of epithelium and fibrotic growth. You can see how much pathogenesis can be very extensive, and the doctor must, first of all, when looking at the patient, The interpreter cannot continue because one of the participants is not muted. This is missed glaucoma before surgical or the result of the incompetence of the surgeon, which led to the changes that led to the trauma.
This can be glaucoma after laser trabeculoplasty and capsulotomy that might first lead to the increase of ophthalmohypertension and then to glaucoma neuropathy, optic neuropathy. This will in turn lead to ulcer and then to the pathology of the anterior chamber angle. Unfortunately, Ukraine is suffering from aggression. February of 2022 changed our idea of the world and of life. And we started receiving a whole different category of patients, severe patients with war trauma, those for whom we need to think and act quickly in order to help them. So first of all, the history has to be collected thoroughly. And here on the slide, you can see the list of tests that need to be performed in order to understand the mechanism of ophthalmic hypertension. And here we need planar tonometry, pachymetry. Here you can see the decrease in pupil reflexes and the color sensitivity. This will allow us to understand if the optic nerve is injured and OCT of the anterior part, the gonioscopy, biomicroscopy, and posterior segment examination. And of course, timely and high-quality treatment. First, we need to use antihypertensive eye drops for glaucoma. Here we can either use beta adrenal blockers or alpha-2 adrenomimetics or the combination of both. We will also need the surgical treatment, and here the choice of specific surgery depends on the mechanism of trauma and on the anatomic condition that the patient is in. So it is decided case on case, case by case basis. We will need artificial tear drops. We will need neuroprotective treatment and the control of pressure, of intraocular pressure once every month, Humphrey control every 3 to 4 months, and HRT OCT control each quarter. The protection of the eye surface. Here we will need to use the solutions like HP, guar, sorbitol, borate, which is an antiseptic and that also forms the adaptive tear film, and those can also be demulcents. Any medications that have no preservatives that aid the cornea in the healing process, they all will improve the compliance of the patient, and they will improve the effectiveness of anti-glaucoma medications. As for the contact lenses, it is possible. We have a different category, different technique for manufacturing contact lenses today. And patients often ask, can they use contact lenses? Yes, they can, because we have novel technologies that don't press into the drainage tract. This is a smart serve technique, and you can see the thickness is different around the surface of the lens. The next technology is gradient humidity content. It allows us to go from 50% to 100% on the surface. We also have the technology for blocking UV light. We can block the ultra high energy light, which all will contribute to protecting the eye and to maintain the refractional capacity to correct the abnormalities, because in a injured eye we might see high level astigmatism and other visual abnormalities, and we can correct those. Of course, our kids get the heaviest burden, and unfortunately today we see terrible eye injuries in children and terrible complications. I am humbled by the practice of our frontline clinics and the Central Ochi Clinic, who all help our patients. This is a case of a 12-year-old who had traumatic cataract, and now, months later, she can see. Here, it is of utmost importance that we examine those kids well, because the complaints that children have might not correlate well with the actual abnormalities that they present. So we always have to perform OCT, we always have to check for macular loss, papillar loss. We need to test visual fields, and we need to perform static perimetry. Gonioscopy, it will help to exclude possible consequences, sequelae of the trauma. We will also always use biomicroscopy and refractometry, because visual acuity is often decreased in traumatic injuries. And often abnormal refraction leads to hyperdiagnosis of glaucoma. We always, in all ophthalmology meetings across the world, have a separate section for pediatric ophthalmology. And today, we also have this topic in our meeting, and I hope that everything that you see, everything that you hear here will help you understand the ways of ophthalmo-hypertension developing, and to choose the correct management, and especially acute management that will save the quality of life. Thank you for your attention. Thank you, Dr. Irina. Of course, there's a lot of information. We will be able to discuss it later. Now, I would like to give the floor to Dr. Barinov and to Dr. Zabrodska. When, on the 8th of July, there was an explosion due to a bomb attack in Ahmadi Children's Hospital. both of these doctors were at work there. And thankfully, they had evacuated the children to the bomb shelter before the hit. Dr. Zabrodska was there with children throughout the whole evacuation. And now I'm giving the floor to her. Good morning, dear colleagues. Today, I would like to present to you our case study of a penetrating eye injury with a fish hook. Injury with a fish hook is quite a rare trauma, and the removal of a fish hook is a complex maneuver, especially if it is penetrating an eye. We had a patient of 15 years old, a boy, who went fishing, and he had a penetrating eye injury with a foreign body. The interpretation will continue once the sound is back. Okay, it's back. The foreign body was at 5 o'clock. I don't know if you can see it here in the picture, but there was a metallosis zone at 5 o'clock. Anterior chamber of the eye, the aqueous humor was transparent, the lens was transparent, the fundus reflex was pink, and we had to be very careful not to remove the foreign body. We decided to go to the OR. We pre-planned a few scenarios of how to remove the foreign body, but the final decision was to be made in the OR. The complexity of removing the fish hook is that it has a very specific tip that may cause additional injury to the eye structures. So in the OR, we decided to remove the fish hook from the anterior chamber with minimal injury to the cornea in order to minimize the traumatization of the eye. We decided to cut off the tip. We used lure scissors in order to cut it off. Due to the shape of the shaft of the hook, it was round. We had difficulty holding it in place, but in the end, it was successful. And then we removed the rest of the foreign body backwards. We repaired all the structures of the eye after that, and this is the eye after the surgery. Dr. Barinov was performing the surgery. We applied the sutures. Repaired the anterior chamber, and that was the end of the surgery. This is what the hook looked like. Here you can see the tip. We used systemic and topical antibiotic therapy, NSAIDs, keratoprotectors, and regenerating therapy. We discharged the patient after 1 week. This is the eye a week after with visual acuity of 1.0. Fortunately, this was a lucky case. The iris was not injured, and the deeper structures of the eye weren't either. After 1 month, the child developed a slight astigmatism, but with correction, the child sees at 100%. Of course, the corneal injuries usually happen in the context of serious ocular trauma, so the treatment is always very detailed and individual. The choice of therapeutic approaches depends on the age of patients, mechanism of trauma, and complications. Thank you for your attention. Thank you. Really, you present just the same way as you work, very precisely. And now I would like to give the floor to Professor Żmurek. He works in the department that is affiliated to our university. And yeah, please, the floor is yours, Professor Żmurek.
Заховали мікрофон, диверсія видно. Доброго дня, шановні колеги. Тема доповіді на слайді.
Okay, dear colleagues, you can see that my talk is about military trauma and its surgical management. This slide shows that we have been working on this since the beginning of war. We've treated over 1,000 patients free of charge and overall 1,600 patients. And we still do our charity work. So in case you know someone you know of cases among the military who need our assistance, you can refer them to us. Statistically, in war trauma, 10 to 12% are open traumas, and out of them, ocular traumas are 5 to 6%. And this is our statistics. Out of our pool of patients, we treated around 100 patients, over 100 patients with open trauma. We had penetrating eye trauma, perforating, and lacerating injuries. The goal of our work was to develop the management of complex surgical approach for patients with severe ocular trauma, using vitrectomy, primary vitrectomy, with further IOL implantation and artificial iris implantation. So we've selected the most difficult patients, 28 who had the most severe traumas. Our primary surgical treatment was performed within the time frame from 14 to 48 hours. Here you can see our materials and methods, 17 patients with Myopia, and the majority had traumatic retinal detachment. This is what a surgeon usually sees when they do surgical debridement. This is a mind blast injury. The patient was taken to the OR within hours. We have been working with such trauma for over 10 years, unfortunately. And here, what you need to do in debriding such wounds is that we need to preserve as many tissues as possible. We shouldn't just dissect everything. And the other decisions are made during further surgical stages. This is an injured iris. We are suturing with nylon. And then we're using the less traumatic materials. A surgeon must know what's happening after they perform the primary debridement. Proliferative process is launching. It has 3 stages. The first one is fibrovascular proliferation. The second stage is cell proliferation. And the third stage is the contraction of the ciliary membrane. Why is it important to know these things? Because up to the end of the second week, there is a contraction of the membrane, and retinal detachment may happen. So the debridement must be performed within the first 2 weeks. This is a video from the surgery. You can see the place of injury. And when we perform the second stage, its goal is to keep the transparency of the optical discs and to repair the globe structure. Here you can see the drainage of the suprachoroidal space. This is our life hack, so to say. We use 25G cannula without a valve. And our first goal is to preserve the transparency. The second goal is to preserve the structure.
In the majority of cases, almost in all, surgery ends in such severe cases with silicone tamponade. What happens next? Well, you can't immediately do surgical work and do the surgery. Well, what does this period of time gives us? Well, the clarity of the cornea improves, the swelling reduces, and the detachment of the posterior membrane happens, so it's easier to do vitrectomy. And the major goal of the secondary surgical care. Obviously, when we finish the vitreoretinal surgery with silicone tamponade, the silicone contacts the cornea. This leads to, within a month or two, leads to the silicone keratopathy. So what can we do to prevent that? First of all, remove silicone as soon as possible in 1 or 2 months after vitrectomy. Otherwise, you'll have irreversible changes to the retina. Unfortunately, this is possible in only small number of cases because for such severe traumas, they are accompanied by relapses under the silicone. So we've developed the technology of formation of the net that doesn't allow the contact between silicone and the cornea. This allows to sort of preserve the eye. And then when the inflammation passes, perhaps do an intraocular correction. So here's the second stage. A silicone oil was injected, the contact of silicone with the cornea. And then we've removed the silicone to avoid this contact. Here's the net that I've talked about. It has a pentagon shape. We do not need to incise the conjugate. It's like a 5-point star. Point of entry, point of exit. We create 2 stars like this if necessary. The higher viscosity of the silicone, the less area of the squares. We even developed special formula that allows us to predict what kind of net has to be soon for the silicone to not enter the anterior chamber. Then the removal of the silicone, we can see that holds its back. Usually in the incision points, we have microhemorrhages, and then above the net, there is a fibrous film. And this adds to the opportunity to creation of such a membrane. Later on, what happens next? Then we need to be thinking about when we remove the silicone, we need to think what we're going to do to these patients. We plan intraocular correction and implantation of artificial iris. What are the indications for implantation of artificial iris? That's when the acuity of eyesight is more than 0.1, eyesight is larger than 9 millimeters, and iridia. This is an aphakia in combination with iris defects for more than a third of its circumference, and of course contraindications to implantation of IOL and artificial iris. These are inflammatory diseases of the eye and its annexes. It's also secondary glaucoma, decompensated, intraocular neoplasms, early stages of trauma before 6 months. So thinking about implantation of the lens or iris, you can only start doing that after 6 months post removal of the silicone when the eyesight function has recovered, and of course general diseases that are decompensated. Of course, as I've said, we've been working on trauma for quite a while, and including combat trauma. This implantation of artificial iris since 2006 or 2007. These are 12. This is a 12-year-old surgery. At that time, we used a Russian-based artificial iris. There was a set of the lens iris complex. So we have more than 15 years of experience. Of course, following the beginning of the full-scale invasion of Ukraine, the interpretation will continue when the sound is restored, because we didn't know when to take the materials. Yeah, we had these patients. They were oriented to me as a surgeon. They were referred to our clinic. So we started using a Germany-made artificial iris. It's by Human Optics. We made approximately 8 surgeries like this. It's not a lot, but then you don't get many patients of this kind. Here we have modification of lemonade technique. The eye, following 3, 4 stages, following silicone removal, stabilization of the eyesight. This is the corneal tunnel. These are the sutures that allow to prevent the fall in of the implanted material. We implant the interior chamber, we put it onto the sutures, and then using the conducive needles, so it's a flange technique fixation, according to Lemonade. One leg. So it turned out that this was more of a technique-based surgery compared to the Russian ones. You can see that you don't need to make any flaps, you don't need to create Schurman scleral suture. So it's quite an advanced technique, and that's post-operative. This is a table of intra-operative and post-operative complications. I've combined these 2 stages after we've made this iris because we don't have a large sample, even if the indications of human optics is that we've only done surgeries to 8 patients. So what are the intraoperative complications? Are the bleeding from the remains of the iris, and then of course emphysema, hypotonia, ophthalmic hypertension, swelling of the cornea, and the most serious are the late postoperative complications, the secondary glaucoma. The early ones, they can all be cured. Intraoperative ones can manage as well. And we had 2 cases, and in these cases we installed METAF valve, and we use special into the posterior chamber from the ciliary body. That's the way we managed it. In other cases, we managed to do without. So when implanting the artificial iris, there are 2 problems. One is the pressure, and the other, you need to take care of the condition of the cornea. This is the acuity results, and finally the conclusions. In these severe cases of open eye injury with bulging of the membranes, which is combined with traumatic aniridia, aphakia, and traumatic cataract, it makes sense to treat surgically in stages. First, by performing vitreoretinal surgery, the goal of which is to achieve the clarity of optical environments and reposition the retina. And the second stage is the intraocular correction and implantation of the artificial iris. The second one concerns the timelines. The secondary debridement, that all has been done not later than from 3rd day to 2 weeks. And this is very important. I mentioned all the time, these are the standards of NADA, the head, eye, and then the limbs. Even if the patient is unconscious and are in intensive care unit, even if they have tracheostoma, these timelines need to be considered and surgery must be performed. For the limbs, the bioprosthetics are available now, but with the eye, we may actually lose the time. So from the 3rd to 14th day, these are the timelines of the first surgery. This is very, very important. Thank you very much. Thank you. Thank you, Petro Vasilyevich, for such an interesting work. And, for great surgery, when we did plastics with implantation of the iris, but it was very, very different back in the day. Dear colleagues, we are continuing our conference, and we're passing the mic to our young assistant professor. He is a PhD, the managing of combat retinal trauma. I would like to mention that Volodymyr Sanin works at the National Hospital, National Military Hospital, and has an incredibly extensive practice, but also works at the Hospital of the Home Office. Thank you very much, Petro Vasilyevich. Thank you for lovely presentations. This is a very relevant topic. When preparing this concept of the management of retinal trauma, what we started with, we posed a question. Can you consider this separately? Can you actually look at these patients with retinal injury in a separate fashion from their general condition? And then moving on to the relevance. Around 12 to 14% of cases of trauma belong to the eye injury with different stages of retinal injury. Of course, this data is somewhat variable depending on the military unit and depending on the country of origin, but they all end the same. This is reducing of the acuity and reduction quality of life. And it's key aspects of improving quality of life of such patients have been determined. These are medical ones, the prevention, diagnostics, treatment, and rehabilitation. This is resolvement of the consequences, social, economic, and psychological, and the experience, international cooperation, and our individual national experience. And we just had an opportunity to consider that in the previous presentations. Is this issue relevant? We decided to take a look at the Global Peace Index. This is the annual global report from the Institute for Economics and Peace, which is based on 8 key aspects: the level of internal security, internal and external conflicts, and the level of militarization of the country. And the higher the rating is, there's a higher chance of injury to the eye organs in the citizens of this country. We are on the 159th place, so we have one of the highest probabilities of injury of the retina, not only in the military personnel. Here we're talking about all citizens. This statistics relates to all. And if we take a look at the map of military conflicts that currently happen in territories of different countries, we're also take one of the leading spots here, that the data calculates the number of deaths on territory of a certain country. And at the same time, they also consider the century losses, and we also take one of the leading places. And as to the prevention of the injuries, the key points are the education training of the military personnel. This is the education training of the medics and paramedics who are going to be providing that primary medical care, the use of protective equipment. It has been studied that the use of protective equipment is not enough. It's not sufficient. With variable data, only from 10 to 25% of soldiers use protective equipment at all times. Most military personnel, military staff do not use protective equipment at all times. A prompt and quality medical care, nutrition, and etc. So we've decided to split the retinal injury into 2 big groups: structural changes, functional changes. With the structural changes, these are degenerations, detachments, atrophies, hemorrhages, fibroses, and functional ones are reduction in acuity, blindness, metamorphosis, flotation. So according to this, we know what the diagnostics is going to be. On our part, we may talk about ophthalmoscopy, OCT, ultrasound, P-scan, and FAG. And when talking about functional assessment, there are also a number of techniques. When looking at the methods of treatment for retinal injury, the concept is built following way, that at the different levels of evacuation, medical care, this is primary medical care, stabilization, and primary debridement. For surgical methods, these are vitreoretinal and laser ones. These are inpatient based. This is 3rd level kind of care that is provided at the hospital level. And then we're talking about conservative treatment and rehabilitation. Among the conservative treatment, this is pharmaceutical treatment, nutritional management, and for rehabilitation, this is psychocorrection, optical correction, and accompanying treatment. With the consequences of retinal injuries, in addition to structural and functional changes, we need to talk about social, economic, psychological consequences, and possible rehabilitation events. So answering the question whether we can consider the methods of management of retinal injury separately, only within the competency of ophthalmologists, no. We need to stick to the principles of integration of key aspects to improve the quality of life of the patients. Talking about the practical recommendations, what can we do and how we do the examinations. Obviously, it's an ophthalmoscopy. The picture may be very different. These may look like a bulging, lacerations. These can be injuries to vessels and macula and detachments of different localization. And so, depending on this, the definition of the management is going to depend on the vitreoretinal surgeon at the first hospital level when the patient is admitted to the hospital to a specialized site of care. What else is available to us? The OCT. OCT can be used both for diagnostics and basically for further monitoring of such patients. The changes may also be very, very different, and they can be differently expressed. And for patients as a tool of control, they can actually show themselves pretty well. What's also important to us, what should we do when we get a patient referred to us after vitreoretinal surgery? We take them for monitoring. We need to support the functioning of the retina. According to international guidelines, the thing AREDS2 nutritional formula is recommended. You can see it on the slide. It improves bioavailability, accumulation of lutein, zeaxanthin, and improves optical function. In post-operative period, this is recommended. If we take international experience, for example, the military personnel of the United States of America, Canada, and Israel, they have in their nutrition, they have balanced nutritional supplements and which take into account the recommendations of AREDS2. So we can also use them quite confidently. If we're talking about the rehabilitation events, this formula is also going to be very helpful. As to the addition to the principle of combined integration, in addition to ophthalmological principles like monitoring at the further stages, we need also consider to supporting therapy and determine the need of the patient in psychological support, because very often they don't know who to talk to. So we need on our own recommend, perhaps do psychological correction of such patients. We need to provide recommendations for social adaptation, work together with rehabilitologists, provide the patient with educational and other resource for adaptation. There are many programs of artificial intelligence now. Patients have an opportunity to get to know modern technology in order to stay in line with their modern life, and support programs. Of course, we know that the patients with retinal injury, they do not lose their social role. They may lose their jobs, and so they need support in these complicated situations. Thank you very much for your attention. Thank you. Thank you, Volodymyr Volodymyrovich. This was the concept of management, which is very important in military time. Dina, we're happy to hear from you now. We've finished our part of the presentation, so I would like to say that we should be in time. We should have about 10 more minutes for discussion. And if possible, I would like to say what I think about on some of the presentations, because I really like the presentation about melanoma, because we have a problem in Ukraine with beta applicators. They can be imported, but we don't have an official import of beta applicators, because for that you need to have special broker. You know, we just don't need a special broker in order to officially import say the things that we need to save the eye. So beta applicators. So we are very pleased that you do this in all situations, and we can share this experience. And of course, your presentation on conjunctivitis, it's one for the ages, because it's the experience of every doctor, and it's very important that you and every practitioner who attends can use your recommendations. Incredibly interesting was the problem of nearsightedness that Professor Marat referred to, and these small doses of atropine. You know, there aren't massive randomized trials, but every professor, every clinician have their own experience with these small doses of atropine. And as was clearly formulated, that in combination with the right correction, we can slow down the nearsightedness in 80% of cases. This is an incredibly important point. This is what I think about it. And I would like to thank you for all the presentations that happened today. And I would like to pass the word on to Żmurek. Dmytro Vasilievich is from Vinnytsia. And because of that, I wanted to say that so are you. And I think he even learned with your father.
Yes, Dina, hello. I know your father. He is Professor Mostovy in Vinnytsia University. He taught me while I was studying, so please say hi to him. I even referred the patient to him once. I will. Thank you. I'm very pleased. He lives here in Israel already. I know, he's impossible to forget. And if I may, I will ask a few questions and maybe some comments too. As for the flange fixation, I work with artificial lens fixation. I have been for a few years, and there's a thought that polypropylene undergoes biodegradation. It is proven already for 8 zeros is 16 to 18 years. For 10 zeros, it was even less. So my question is there a differentiation per patient of what way of fixation to use? Maybe if it's a young patient, then we can use 7 zeros, 6 zeros, when biodegradation is longer. And for older patients, we can take 9 zeros, 10 zeros, maybe, for example. What is your opinion on that? Also, another thing is that Hortex can be used, and it's becoming more and more popular, but it is more crude. And my question is whether you use it and what's your experience. Maybe can we give the floor actually to Professor Markovich, who uses it more?
You understand English, I know, because it was what in English?
So maybe you can translate the question, yes.
Окей. Я перекладу на иврит, так буде легше. אני אתרגם לעברית ואתה כבר תענה באנגלית, יהיה יותר קל. מה שהוא שאל, שמה שהם יודעים שהתפר שאתה משתמש, שהצגת, עם הזמן, הוא גם משתמש ותופר עם התפר הזה, עם הזמן יכול לעבור פירוק, ואם יש השפעה של הגיל על החלטה איזה חומר תפירה, איזה תפר להשתמש. כלומר, אם זה בן אדם צעיר, האם כדאי אולי לשנות חומר, והאם משתמשים באורטקס, כי בנקודת הנחה שיכול להיות שעם הזמן, הבן אדם הצעיר הזה יתפרק לו התפר, ועוד פעם החוט, ועוד פעם העדשה תגלוש.
So, the 7O or 6O proline, I don't think it will degrade because it's very thick. So it's compared to the 10O proline that it's very, very delicate. The 7O is very thick. So this is a very stable suture. And with the flange technique, it's very stable. We have several years and it doesn't degrade and it's not losing the strength. So I think it's a very, very good technique. It's very easy if there is no capsular support to implant 4-eyelet IOL. And in trauma, it's a very, very good option when you don't have zonules to implant such a lens and fixate it. And it's much easier than the Yamane technique. As of age, so if it's children, I don't have experience with this suture in children, and I didn't use it because I'm afraid that the sclera of the child will be too delicate for this flange. So like in Marfan, in children, I use Gore-Tex, and there is a new, it's not new suture of the Gore-Tex, but it's new in ophthalmology. It's called Ceramon, and it's a German Gore-Tex that it's very, very thin and easy to manipulate and also to perform knots. It's not bulky as the usual Gore-Tex, and it's very, very good. And you can even introduce it to a 30 gauge needle. So in children, I use the Gore-Tex and not the Prolene. But this Prolene 7.0, it's not degrading, so it's very, very stable.
Okay, thank you very much. גם אני למדתי.
Дякую, шановному професору. І з приводу дитячого
Thank you, dear professor. And as for pediatric retinal detachment, a question to Rita Ehrlich. How often do you perform combined surgeries? So in one stage, you perform the removal of the lens and IOL implantation, and what IOLs do you use?
שמעת באנגלית? שאלה אלייך, את רוצה שאני אתרגם?
כן, תתרגמי לי רק את השאלה.
ואת תגידי באנגלית. השאלה היא, האם יוצא לך בסיטואציות של טראומטיק קטרקט וטראומות שונות, המורכבות, המסובכות, עד כמה יוצא לך לקבל החלטה בו זמנית כבר להשתיל עדשה אצל הפציינטים הצעירים, באיזה גיל את מקבלת את ההחלטה הזאת, באיזה עדשה משתמשת, ואיך את עושה חישוב, מאיזה גיל את מקבלת החלטה שבאותו רגע את עושה הכל, ובאיזה סיטואציות.
Well, it depends, of course, on the complexity of the case. If I do the cataract, if I put the lens in the first surgery, usually I prefer to do the whole surgery with the implantation of the lens within the same surgery. But if I think that the prognosis is not very good and I leave silicone oil, sometimes I do prefer to do it with the 2 steps when I remove the oil to do the lens implantation. But usually I prefer to do in every age, maybe not in babies, but in every age to put the lens in if I think it can be performed safely. As far as biometry...
אני יודע לך. לא חצרה הרבה. מה לעשות?
As far as biometry, we usually use, if the cornea is, you can do a biometry in the eye that is traumatic, then we do it according to the other eye, as far as the calculations for the lens. So I hope it answers the questions.
Thank you very much. תודה רבה, דякуємо. Other questions? עוד שאלות? לא יודעת איזה שפה אני מדברת. Є ще питання?
Ви знаєте, то в нас одні запитання, можливо, в наших колег є запитання до нас.
You know, it's been us asking questions. Maybe you have any questions for us. Well, I always have comments. We will be glad to hear from you. Well, I am impressed with the work that ophthalmologists in Ukraine do during such a difficult situation. I've listened to all of the talks on trauma. This is a topic that's very close to us, and maybe next time, if we meet, and I hope we will organize more events together. Really, the question of reconstruction is very hot. And the work performed by ophthalmologists is immense. And I would like to say that in my opinion, of course, there are no bright sides to war, but due to the war, we make a lot of developments and we progress a lot. And I've witnessed this when you presented your techniques. My question is whether it is all recorded, statistically documented, whether there is shared national statistical work in the country so that we can collect it later and to recommend and publish so that others can learn from it, like first aid in lack of resource setting. All of these things need to be known. So do you document your experience? Maybe the last speaker can talk about it. I will answer the question. Well, we don't have official state statistics since 2018. Unfortunately, we haven't had it. But locally, we collect the data, and each facility reports on the number of surgeries that they performed. The only thing is, during the war, it is considered a military secret, so we cannot publish them now, so that the enemy doesn't know how many wounded we have. In the military hospitals, however, everything is recorded, and we have the National Health Care Service of Ukraine that collects all this data in order to provide the financing to the institutions. And unfortunately, our time is coming to an end. And I would like to thank all of the speakers. You gave us very interesting talks. You gave us practical hands-on experience. 85% of our participants are practitioners, those who do clinical work. And we have started this cooperation, and I would like to thank you. I would like to thank Katerina Fechuk, who is our ambassador in Europe, in Israel. And we are all together in unity, and we are fighting for victory. We resist. We are performing an act of scientific resistance by being here. Thanks God, we had no air raid alarms today. We haven't had any yet. And we are standing our ground with both feet. And I would like to wish to our Israeli colleagues, and I actually performed one surgery in Israel, so I know also what Israeli medicine is, and I am very respectful towards it. I always hold it as an example, and a lot of Ukrainian doctors study in Israel. And I would like to wish you peace, so that you don't have to have soldiers everywhere all the time. Like when I came to Israel once in the hotel, I saw armed soldiers. Actually, that will be always like this. Yeah, it is safety. I need to say that God is in the sky and God lives in Israel. So I believe in both of our countries' victory.
באנגלית הכל בסדר, לא לתרגם, אני אתחיל לבכות כרגיל, אז נדלג. вони розуміють, все нормально. Зрозуміло, я не знала, чи не чула англійську мову.
Hear you, they understand you, they heard the translation. Good. And I would like to play your song again. It is an anthem for Israeli and Ukrainian ophthalmologists. It is an anthem of your soul, Dina. And I would like everyone to hear it. Thank you.